Good afternoon, everyone. Today, I would like to deliver my presentation. Topics names: comparison of bladder rectal dose with single channel versus three channel vaginal applicators in HDR electronics brachytherapy. This is a table of contents. Introduction to brachytherapy. Everybody knows brachytherapy is an internal radiation treatment where a radioactive source is placed inside or near the tumor. But in here, we show no need to radioactive source for brachytherapy. We only use 50 kV X-ray. This methods delivers a high dose or of radiation to the tumor with minimal exposure to surrounding healthy tissue. Historical development and technological progress, the evolution of brachytherapy. In 1920, 1930s, discovery of radium, everybody knows. Radium-226 used as a radiation source for cancer treatment. In 1940s, 1950, development of applicator. In 1960s, 1970s, advancements in techniques, use of cesium-137 and iridium-192 for treatment. In 1980s to 200s, modern era, introduction of HDR brachytherapy. The development of computer-based treatment planning and imaging, CT-MRI, image-guided brachytherapy. Now, 2005 to present, electronic brachytherapy is a modern innovation in internal radiation therapy. Everybody knows advantage of brachytherapy. We can see in the figure 3D CRT, IMRT, VMAT, all image we say healthy tissue gets some doses. But in brachytherapy, we can see less dose healthy tissue. In behind of physics, external brachytherapy dose fall up rapidly, but EVRT follows inverse square law. Background in electronic brachytherapy. What is electronic brachytherapy? A form of advanced internal radiotherapy where a shield miniaturized radiation source is placed inside or next to the area requiring treatment. No radioactive radiotherapy. Use as a high dose rate, low energy excess source, precise radiation directly to cancerous sites. Operate at 50 kV and 300 microamperes, 50 watts. Used as a boost therapy after EVRT. Isotope free, minimal shielding requirement, allows medical staff to remain in the treatment room. One system, multiple solution using EVRT. You can see in here, breast, gynecological treatment, skin, neuro, brain, rectal, and prostate. IORT, intraoperative radiotherapy, is a special radiation technique that permits the administration of high radiation dose, 21 gray, in a single fraction during surgery alone or as a boost techniques. It allows direct radiation to the target area while sparing normal surrounding tissue. IORT is a prepared therapy for several regions. IORT is a shorter procedure. IORT is given a single dose instead rapidly over several weeks. IORT has fewer side effects compared to EVRT. Patient criteria for IORT, tumor size less than 3 centimeter. System components, this machine weight 92 kg, cooling mechanism, mechanical arm, calibration tools, touch skin panels. Bladder and rectal dose in brachytherapy. Why bladder and rectals are critical? Both organs are adjacent to the target area in gynecological brachytherapy, making them susceptible to unintended high radiation doses. Significance in brachytherapy. The bladder and rectum are organs at risk due to their close proximity to the target area. Proper dose management minimize complications like radiation cyst, bladder, and procyst rectum. Dose constraint, we can see 2 cc is used commonly use a matrix which measures the maximum dose to a small volume of these organs. Bladder, we know, less than 90 gray, rectum less than 75 gray. Vaginal applicators in brachytherapy. Single channel applicators and multi-channel applicators. Single channel applicators, simple cylindrical design, commonly used in intercavitary brachytherapy, deliver a radial dose pattern, often leading to hotspot near the applicator surface. But 3-channel includes peripheral channels that enable asymmetric dose delivery, designed for better coverage of the tumor and sparing of critical organs. Often used in 3D treatment planning system for more precise dosimetry. We can see in here vaginal applicators, iridium 192. In here, we can see bladder, rectum, 50% acidose line. Bladder B35s covers 47.7% volume, but bladder B35s for 50 kV source to 7.4% only, very less according to iridium 192 for rectum also. Targeted therapy, that's been IORT, we can see in here. Iridium 192 HDR and soft jobbed 50 kV source, we can see in here. Best 50%, coverage 30%, and for iridium 50% 19.8. That's mean we use 50 kV source, less coverage OAR. Initial and daily source calibration. Pre-treatment, a source dose calibration is performed prior to every fraction, source integrity, timing and dual position accuracy. During treatment, kV, MV time monitorized. Objective of the study: to compare dramatically optimization between the single channel and 3-channel applicator using DVAs treated carcinoma of the cervix with intercavitary brachytherapy, to evaluate bladder and rectal dose difference and access dosimetric superiority using various dose index parameters in HDR brachytherapy for cervical cancer. To assess the clinical effectiveness of 3-channel and single-channel applicators in improving vaginal disease coverage while minimizing dose to the bladder and rectum. Materials and methods. The following materials were used: 50 kV, brachycare software, vaginal applicators. Patient evaluation, patient selection, undergoing intercavitary brachytherapy for cervical cancer at the Ghazi Cancer Center, Dhaka, Bangladesh. All patients received EVRT, 50 gray in 25 fraction, followed by intercavitary brachytherapy, 21 gray in 3 fraction. We can see in here, ICRU 89 and ESTO recommends for dose volume reporting. Dose reporting OAR, level 1, rectovaginal reference point dose, 0.1 cc, 2 cc for bladder rectum. Level 2, bladder reference point dose, 0.1 cc, 2 cc for sigmoid, bowel, vaginal point dose at the level of source. Dose constraint. Bladder 2 cc, less than 90 gray, 0.1 cc, 110 gray. Rectum 2 cc, 7.5 gray, and 0.1 cc 8 centigrade. We can see in figure red one 0.1 cc, single channel applicators. This is a dose distribution. Single channel applicator analysis of dose, bladder dose analysis, max dose 50 gray, DMED 13 gray, and 2 cc 10 gray within constraints. Rectal dose analysis, max dose 18 gray, med 16 gray, and 2 cc 804 centigrade within constraints. 3 channel applicators, analysis for 3 channel applicators, bladder dose analysis. We get max dose 29 gray and dmin 80 gray, 80 centigrade, 2 cc 11 gray within constraints. And rectal dose analysis, max dose 31 gray, minimum 34 centigrade, and 2 cc 767 centigrade within constraints. This is DVH for single channel applicator. This is also DVH for 3 channel applicator. Both DVH we can see here, blood and rectal dose is very less compared to single channel. Discussion. Kind findings. Bladder dose. 3 channel demonstrated reduced bladder doses compared to single channel applicator. Rectal dose, similarly rectal dose were lower with 3 channel due to its enhanced dose sparing and conformal delivery capabilities. Challenges. Patient variability and anatomical difference may affect the general stability of results. A small sample size could limit statistical significance. The study focused only on dosimetric comparison. Clinical outcomes, toxicity, tumors control are not evaluated. Conclusion. 3 channel applicator outperforms the single channel applicators in HDR electronic brachytherapy by better sparing bladder and rectal while ensuring effective tumor coverage. It improves dose conformity, reduce radiation-related complication, making it the preferred choice for precise treatments. Further studies are needed to confirm this finding and assess clinical outcomes. Thank you for your attention.